It was 60 degrees yesterday in Denver, but it is snowing this morning. So, okay, so we've heard a fair amount about type 2 diabetes this morning, and I want to go into a bit more physiology. And the first question, before we start talking about the management of type 2 diabetes, is really the question of whether type 2 diabetes in kids is the same as it is in adults. And the answer is, I actually don't like touching, is yes. And as I'll show you very briefly, that the underlying pathophysiology of this disorder is the same in kids as it is in adults. It's this one. That. And the answer is also no. And type 2 diabetes in kids is different than in adults in important ways that have implications for our approach to treatment. So let me just spend a little bit talking about this. So surprisingly, no one showed this slide yet this morning, and I would have expected somebody would have. And basically, this shows the normal relationship between insulin sensitivity and insulin secretion. So people have talked already this morning about those two components, insulin resistance and insulin secretion, but in the normal situation, what we find is that as insulin sensitivity falls, as insulin sensitivity falls, insulin secretion in the normal person rises. And as long as insulin secretion sufficiently compensates for that worsening of insulin sensitivity, the patient maintains glucose tolerance. What happens is that if they are unable to maintain sufficient compensation for changes in insulin sensitivity, then you begin to lose homeostasis. And impaired glucose tolerance and type 2 diabetes develop. So I think, whereas in the past, and still to some extent now, there's been a lot of attention paid to insulin resistance as the primary driver of risk for type 2 diabetes and type 2 diabetes, I think we're becoming to appreciate more and more that in fact, it's not the insulin resistance that is the cause of type 2 diabetes. It may create the risk, and maybe this is how this whole deleterious process begins. But if you can maintain your insulin secretion sufficiently compensating for that change in sensitivity, you maintain normal glucose tolerance. And we know that the vast majority of people who are insulin resistant never develop diabetes. So in fact, diabetes is a disorder of failure of beta cell compensation. I think that's becoming clearer and clearer. And so what we see is that if we look at insulin sensitivity measured in a gram, the M value, as you go from normal glucose tolerance to impaired glucose tolerance in type 2 diabetes, there is indeed worsening of resistance, loss of sensitivity. But as you go from normal glucose tolerance, impaired glucose tolerance to type 2 diabetes, you have a very substantial decrease in beta cell function, the insulin secretion. So yes, worsening resistance plays a role here, but if you maintain your secretion sufficient to compensate, you don't develop diabetes. You develop diabetes when your beta cell is failing. And we see the same thing. I mean, the same thing is happening in kids. So the underlying physiology in children is the same. Inadequate compensation for insulin resistance. And just a couple of slides to show you that, interestingly, this actually can be demonstrated prior to the development of diabetes. So this is a study from Silver Arsenian's group showing that even in adolescents with normal fasting glucose, there is a loss of insulin secretory compensation for resistance, measured as as glucose disposition index. So there is a decrease in insulin secretion relative to sensitivity, even when you get to blood sugars of 90 to 100 fasting, and certainly when you get into the impaired glucose tolerance range. Impaired fasting glucose range. And the same is true if we look at 2-hour glucose. So again, the top is a measure of insulin resistance, and we see that as we get from less than 120, 120 to 140, 140 to 160, which is now impaired glucose tolerance, resistance is worsening, but more dramatically is loss of insulin secretion. So it's not, again, insulin resistance that's worsening as you increase your 2-hour glucose. In fact, it's insulin secretion. And there's this concept of the disposition index, which is essentially a mathematical way of expressing insulin secretion as a function of insulin sensitivity. Does that make sense? So you're going to see this again and again. And we can talk about the way it's calculated. It's not important. But essentially, it's a way of correcting for the amount of sensitivity when you measure insulin secretion, right? Does that make sense? So how well are you compensating? As the ODI decreases, you are compensating less well for the degree of sensitivity. And you see that there's a progressive decrease in that compensation that's occurring in insulin sensitivity. Okay? So in these ways, type 2 diabetes in kids is exactly like type 2 diabetes in adults. So here's the same thing in adults, and what we see is that after diagnosis, insulin sensitivity doesn't change very much, but there is continued loss of beta cell function. So I think one of the messages in the last few years is that type 2 diabetes, as we were told in the first talk, this is a disorder of beta cell dysfunction, perhaps set up by resistance. So in these ways, type 2 in kids is just like it is in adults, the same underlying physiology. What I want to talk about now are some very unique aspects of type 2 diabetes. Now, this is all based in studies in the US, but there's no good reason to think that the situation is really different anywhere else. So, first of all, I'm going to tell you that type 2 diabetes remains a rare disorder. We're all very worried about it. It's sort of frightening. It's telling us a lot about what may be happening in our society, but this is a rare disorder. This has implications for studies that we designed for this. So Search for Diabetes in Youth was a study put together by the CDC to look at a population-based assessment of current prevalence and incidence of both type 1 and type 2 diabetes in the United States. It was done at 6 centers across the country, selected to represent US demographics. And what they've shown us is that type 2 diabetes in the United States, anyway, is extremely rare in children younger than age 10, regardless of ethnicity. So I'm going to argue that this is a disorder of puberty, for the most part. After 10 years of age, type 2 diabetes represents about 15% of all new cases of diabetes among whites, about 50% among Hispanic youth, almost 60% among African Americans, about 70% among Asians and Pacific Islanders, and almost 90% of American Indians. New cases of diabetes are type 2. However, despite those shocking numbers that we all see in the papers all the time, etc., this remains rare. And the estimate is that approximately 3,700 youth under the age of 20 are being diagnosed with type 2 diabetes in the United States annually. It's a very small number. Millions and millions of adults are being diagnosed with type 2 diabetes annually. We're talking about less than 4,000 children. So by any definition, this is an orphan disease. The estimates are that the prevalence of type 2 diabetes in the United States is about 40,000 under the age of 20. And we'll come back and talk about drug trials and the implications of that number for the design of drug trials. So that's one thing. So this, unlike type 2 adults, this is a rare disorder. Secondly, there's a different pathophysiology here, despite what I told you a few minutes ago. So one thing that's different is that the prevalence of undiagnosed diabetes is extremely low. You may know that estimates are that approximately 50% of adults with type 2 diabetes are undiagnosed. So if you go out and screen, you will find double the number diagnosed. You will identify them in the population. The situation is different in kids. Estimates are from NHANES, which is a population-based survey that's done in the United States every approximately 10 years, is that diabetes based on fasting criteria is less than 1% of patients. And more importantly, a study that was done in a very high-risk group of kids, 8th graders, so the peak period of incidence of type 2, as I'll show you, all obese, and as it turned out, predominantly minority 8th graders. What they found, to their surprise, was that diabetes was present in only 0.4% of these children by fasting criteria. And on glucose tolerance test, 0.1%. Extremely rare to find children who are not presenting clinically. Is that the same experience here? Yeah. Well, this is serious implications for screening and identification of cases for clinicians. What you do find is a fair amount of impaired glucose tolerance, but you don't find much diabetes. This is extremely different than in adults. That has to be telling us something about the differences in the natural history, the time course. This is not something that has a long asymptomatic prodrome during which you can identify affected patients through screening. So that tells us something very important. I'm not sure what it is, but it tells us something very important about the way this disorder develops. Another thing, this is from Sonia Caprio's group in Yale, that's quite interesting and different than adults. So she took 102 kids, and we're just going to focus on those children who had impaired glucose tolerance. She had about 30% of them had impaired glucose tolerance. And by the way, that number reappears frequently. About 30% of obese children will have evidence for metabolic syndrome, impaired glucose tolerance. The other 60% don't, which is another whole issue. So you focus on the 30% of these kids who had impaired glucose tolerance. And then she followed them for about 2 years. And what's interesting is she found that about 30% progressed to type 2 diabetes, but more importantly, 30% regressed to normal glucose tolerance without any intervention. And this is almost unheard of in adults. So what you see is a natural regression to normal glucose tolerance or transience of impaired glucose tolerance in this population. That's different than you see in adults. In adults, it's usually a progressive, inexorable process unless there's some change, weight loss, etc. This was just left the kids alone and retested them. Why might this be? And the argument would be here. And that is, if you look at insulin sensitivity on this axis, measured by M value in a clan, in girls and boys, what we see is increased insulin resistance as children go through puberty, peaking at around Tanner stage 3 or 4, and then improvement in that sensitivity as they come out the other side of puberty, returning to sort of pre-puberty levels, normal adult levels, as they come out of puberty. So what we can see is that there's an opportunity here for these children to rapidly rise on the insulin sensitivity, or deteriorate on the insulin sensitivity curve, and perhaps not be able to sufficiently compensate during this period, so their glucose gets worse. But as their sensitivity improves again, they're back up on that curve, and they return to normal glucose tolerance. What does that sound like, by the way? There's another sort of physiologic state where we see this all the time. Gestational diabetes. Exactly. So I think we're developing this concept that this may, in fact, be very analogous to gestational diabetes. You take a person at risk, put them in a stressful situation, puberty here, pregnancy and gestational diabetes, and then you take that stressful situation away, and they recompensate. Now, just like gestational diabetes, you would speculate that this might be a marker for future risk in these patients, right? Just like gestational diabetes. Some women continue to have diabetes when the pregnancy is over. Some remit and then get it again, either in the short term or in the long term. So we're guessing that we may be seeing something very similar here, where puberty is the analogy of gestational diabetes in these kids. Okay, so that's the background. So I was asked to talk about sort of treatment options. And let me show you what our current evidence base is. And this is not going to take very long. The first drug that was approved for treatment of type 2 diabetes in kids was Metformin. It's widely used in adults with diabetes. It's got a lot of nice features. But let me show you what the evidence base looks like. So they screened 481 kids in this study. 399 of them were not randomized. So they ended up randomizing 40 in each arm. So 10% of the original, less than 10% of the original population was sort of, 20% of the original population was randomized. But look at this. In the Metformin arm, 19 patients completed out of 42. So about 45%. And in the placebo arm, 3 patients completed this trial. And based on this, the FDA approved Metformin for the use of children, for the use of in children with type 2 diabetes. Probably one of the least impressive registration trials ever done. So that's the evidence base for the use of Metformin in children. Now, it actually is a good drug. I don't mean to say it isn't, but this is the evidence base that we're dealing with. A few other things that you can see in this trial is that there were a number of differences in the 2 arms. Randomization problems in small trials, right? So the fasting plasma glucose in the placebo arm was 11 versus 9 in the Metformin arm. So you're starting out with a huge difference. And the A1C, 9 versus 8.3, with 50% of the placebo arm, with 50% of the placebo arm having an A1C greater than 11 versus 20% in the Metformin arm. So this is a real stinker of a trial. And it just shows you the problems you can run into with small clinical trials. However, there was a difference in decrease in A1C in the Metformin arm versus the placebo arm by about 1%. And that's what was expected based on adult studies, about 1%. So this drug was approved. This is the only other published drug trial in type 2 diabetes in kids, and this was a study looking at Metformin versus the sulfonylurea glimeperide. And I'm not going to show you the sort of flow diagram, but this turned out better. They had equally matched groups. Most of the patients finished the trial, so it was reasonably good. And what we see is that glimeperide in the black versus Metformin in the white. Glimeperide is not quite as good as Metformin in decreasing A1C at either 12 or 24 weeks, it's similar but not quite as good. So certainly no benefit over metformin. And although there was improvement in fasting glucose at 8 weeks, that was lost as you got out in the trial. And as I'll show you in a little bit, with some data from adults, that's not surprising because sulfonylureas probably only work for brief periods of time in reality. And we'll come back to that. Metformin versus rosiglitazone study was completed probably 10 years ago now. It's never been published. I actually reviewed it 3 times for different journals. It was fine. I think the company withdrew it each time before it was published. Yes, raised eyebrows. This has never been published. So that's prior to the Today study. That was the entire evidence base for treatment of type 2 diabetes in kids. So let me tell you about the Today study. So the Today study, let me see. So the Today study was actually put together by NIH. They held a consensus conference in around 2000 to get people together to say what are the unanswered questions in type 2 diabetes, what do we know about it, some of the demographics, and a bunch of people were in a room and we said, well, we know it's occurring in pretty socially challenged kids, we know that they're obese, we know that they're poor, but we don't know anything else about it. We don't really know how to treat it. There's a lot of argument about metformin versus insulin, etc. So they issued an RFA around 2001 for folks to participate in a trial to look at treatment options for kids with type 2 diabetes. And ultimately put together a consortium of 15 centers around the country representing more or less well the demographics of type 2 diabetes in the United States. There's some serious holes in it, but so be it. And to undertake studies, and we then met for about 3.5 years to try to decide what studies we were going to do, and decided that really the question, given the background I told you about that worsening sensitivity that occurs during puberty, and what we know about beta cell physiology, that stress on the beta cell because of sensitivity, worsening sensitivity, and the need to compensate may itself be a bad thing for the beta cell. The question we wanted to ask was, does it make sense to aggressively treat kids during this period of worsening insulin sensitivity to prevent them from sort of having progressive beta cell failure and perhaps end up with a situation after puberty in which glycemic control is better? So another way of saying that is that the hypothesis was that early initiation of combination therapy in kids with type 2 diabetes will be more effective in promoting sustained, durable glycemic control than monotherapy with metformin and sort of the standard kind of start one drug and then let it fail and start another drug and let it fail. And we wanted to know whether aggressive treatment of adolescents with onset of diabetes during the period of pubertal insulin resistance will lead to improvements in their post-pubertal outcomes. So we designed a trial in which we would compare 3 treatment regimens. One is metformin, which was clearly standard therapy at that time based on that beautiful registration trial I showed you. Compared to 2 approaches to improving insulin sensitivity. A pharmacologic approach with an insulin sensitizer, rosiglitazone, which made sense at the time. Some of you know that that was problematic eventually, versus a lifestyle approach to improving insulin sensitivity. So adding to metformin something to improve insulin sensitivity. And what we looked at was a glycemic outcome. So the outcome, what we call failure or loss of glycemic control, was an hemoglobin A1C greater than 8% for at least 165 days, or we got to the end of the trial and the kid's A1C was 10%. He wasn't going to get better in a few months. Or the inability to wean from temporary insulin therapy that was started due to acute metabolic decompensation. So the kids, they start developing ketones, they get decompensation. Once they were better from their illness, we had a forced weaning algorithm. You had to wean by X amount of insulin every week, and if you were unable to do that without ketosis reoccurring, then that was also called failure. The study design included a 2 to 6 month pre-randomization run-in period, which we considered to be critical because this is a low socioeconomic status, challenged population, and we needed these kids to stay in this trial for 6 years. So we had to have something to demonstrate that they were able to comply with the requirements. So we provided standard diabetes education, and by the way, this is now available for public use on the Today public website. These are beautiful materials designed for children with type 2 diabetes in Spanish and English that are now available for download. If you have a color printer, they're great. We weaned them off any other diabetes medications, which it turned out really were just insulin. We titrated metformin as tolerated. They had a goal of 1,000 milligrams twice a day, but they had to tolerate at least 500 milligrams twice a day to be in the study. We assessed their ability to adhere to the protocol, i.e. they could not no-show. They were allowed to call us 1 minute before the appointment and cancel, but they couldn't no-show. And they had to be able to keep their A1C less than 8% for 3 months off of any other medication besides metformin, because obviously 8% was our outcome. All the eligible consented participants were randomized to one of 3 treatment arms that I told you about. We had a 4-year rolling enrollment period, and they were followed for 2 to 6 years with medical visits every 2 months in year 1 and quarterly thereafter. We were taking care of their diabetes. We provided their diabetes medication, their supplies, their testing equipment, all of their care, which was critical to actually getting this done. These were kids who were 10 to 17 years of age. They had to have rigorous diagnosis of diabetes by ADA criteria. This was all adjudicated. Duration of diabetes had to be less than 2 years. As I'll show you, it was substantially less than that. BMI had to be greater than the 85th percentile of diagnosis. That was not a problem. They couldn't have type 1 diabetes. So no pancreatic autoimmunity, and they had to have evidence of retained C-peptide. We had a lifestyle intervention that included a dietary component, which was based on the stoplight diet of Len Epstein. So it's very simple. Reduce your intake of those things that are considered red foods, high fat, high calorie, high carbohydrate density foods. Increase your intake of green foods. Physical activity component, which was both psychoeducational as well as let's go to the gym and I'll teach you how to do stuff. We didn't have exercise classes that had to do with the nature of this study. It was hard to get kids to actually get together. But we had a training component and an important behavioral component that focused on parenting, praise, positive reinforcement of good behavior, because many of these families tend to be very negative in their approaches to behavior. All the educational materials were specifically tailored to the kids. They were specific for race, ethnicity, and language, and they are also available for your use on the Today public website, and they're really quite nice set of materials. Now, whether they worked or not, we'll talk about in a moment, but they are nice. So the team consisted of a personal activity nutrition leader, we called it PAL. So this was basically a trained behavioral interventionist who worked with a psychologist with weekly supervision, taping, review of all sessions to look at adherence to the protocol and effectiveness of the sessions. They met weekly for 6 to 8 8 months in person with the child and the mother, or father, usually the mother. Then they met every other week for 6 to 8 months with a phone call in the off weeks. Then they met monthly with a phone contact in the 2 weeks in between. And then finally, they met quarterly until the end of the study. And the idea here was to have an early intervention and then wean them off into a program that was more like what you might actually be able to do in your quarterly visits in the diabetes center. Okay, so obviously this is not something you can sustain in the diabetes center. So the cohort started out as 1,211 kids. 284 of them were excluded. 116 of them had positive antibodies, which I don't think I'm going to talk about. I think the slides are up, but the bottom line is for the pediatric endocrinologists is we're not very good, at least in our population, at identifying clinically who has type 2 diabetes. 137 of those, so half the kids, were excluded for other reasons, and they were things like not showing up again ever after the screening visit, losing contact, etc. 927 of the kids entered the run-in, and of that, 223 were excluded, mostly for either inability to maintain A1C within the target, or other, which again was things like completing the entire run-in and not showing up for your randomization visit, and never being heard from again. So those of you who take care of these kids won't be surprised by that story. We had one kid who actually called us from the lobby of the hospital for the randomization visit, said, "I'm here," and never showed up in the clinical research unit and was never heard from again. We have no idea. That kid may still be wandering the halls of the hospital. Even though we moved out of that building 5 years ago. So 740 of these kids were randomized ultimately to the study. So what do they look like? So they are median age of 14. Not surprising, based on what I showed you about insulin sensitivity. This is 10 or 4, right? This is the peak of insulin resistance. They had, although, and by the way, the girls were a year younger than the boys, as you'd expect if this is being driven predominantly by Tanner stage. Nobody in this study was less than Tanner stage 2, so these kids were all pubertal. Duration of diabetes, we let them be in the study up to 2 years. We didn't have anybody. The 75th percentile was 9 months, median 5 months. Message is that it's almost impossible to engage kids with type 2 diabetes, not only in clinical care, but in research, once they've had diabetes for about 8 to 10 months. So that's an implication for future study design. They were obese, Z-score of 2.2. They were all pubertal. They were predominantly female. Ethnic distribution is meaningless because we sort of picked it based on the census. A lot of family history of diabetes. About 30% of the kids were born to a pregnancy complicated by gestational diabetes. Now, as we said, we expected that these kids were going to be socially and economically challenged. We didn't quite expect them as bad as it is. So 40% of the kids lived with both parents. 50% of the kids lived with the mother only. And 10% of these kids were living with neither biological parent. Parental education was low. Only 16% of these kids, parents had ever entered college. So parental education was low. And most strikingly, 40% of these kids lived in families where the family income was less than $25,000 a year. So this is a population that is poor with low parental education and family disruption. So, in summary, the kids with type 2 diabetes in the US, which we believe today reflects, are predominantly minority, predominantly female, are late pubertal at diagnosis, have a BMI well above criteria for obesity. I didn't show you this, but you'll see more in a moment. Have a high prevalence of comorbidities that vary by gender and ethnicity. And come from families with a strong history of diabetes, limited educational attainment, and low income. And they live with 2 biological parents in less than half of the cases. Okay, so what did we see in the trial? What we found, actually, was that 45% of these children experienced the primary outcome, i.e. loss of glycemic control, over a maximum follow-up of 72 months. And what we found is that a little over half of the children lost glycemic control with metformin alone, and this was improved by the addition of rosiglitazone with a decrease in the failure rate of about 23%. Lifestyle was intermediate, but not different from either metformin alone or rosiglitazone. If we look at the actual time to event analysis, again, what we see is in blue the metformin, about 50% loss of glycemic control over a period of a few years. Rosiglitazone improving that, and lifestyle intermediate. But what's interesting is it occurs very early on. So these, in fact, lines separate by 6 months. Now, we actually had set up beforehand the DSMB. We said, don't stop us for success, because we want to learn about the natural history of these kids. So we were able to keep going, even though we actually separated by a year. So by 1 year, rosiglitazone was already better than metformin. Okay. So how does this loss of glycemic control compare to adults? So this is the UKPDS. And what I just want to quickly show you, so this is, if you will, failure rate, 7%. What we, what, can I do it again? And if you look here, we've got months, right? We're talking 12 months, we're down to about a 25% failure rate, 50% failure rate at about 2 years. On this x-axis is years. So what we're seeing in UKPDS in adults is very gradual loss of glycemic control on treatment in the adults. So what appears to be the case is that we're seeing much more rapid loss of glycemic control in kids than is seen in adults. And this is, again, another study called ADOPT, looking at really the same comparison, metformin plus rosiglitazone. We'll talk about glimeperide in a second. Improvement initially, and then it's years and years and years before there's loss of glycemic control on these therapies in the kids. Metformin estimate is about 5 to 7% loss of glycemic control in adults per year. We're seeing 25 or more, and I'll show you the ethnic data in a moment, loss of glycemic control in metformin. So there's something different biologically about type 2 diabetes in the kids. Now the glimeperide is interesting because what ADOPT and UKPDS showed us actually is that sulfonylureas are effective initially, but in fact worsen the outcome over time. It's probably bad for the beta cell because it's basically pounding the beta cell to make more and more insulin, which may set up the kind of things that we heard about in the first talk. Now, why did we see loss of control in these kids? So this again is Disposition index. I told you that Disposition index is a way of looking at insulin secretion corrected for sensitivity. And what we see is that there is steady decrease in the Disposition index in the kids on metformin over time, despite treatment. Lifestyle is really no different. Rosiglitazone has some initial improvement, as you'd expect. It's an insulin sensitizer, so you improve resistance. Secretion is still where it was. You get a better Disposition index. But it then parallels. So all you've done is sort of shift the time frame over by 6 months with rosiglitazone. So there's a progressive loss in Disposition index. And what makes this up? So we have sensitivity on this panel, not a lot of change over time. Improvement in sensitivity to rosiglitazone, as you'd expect, but not much change over time. However, decrease in insulin secretion over time. So that loss in Disposition index is predominantly driven by progressive beta cell loss. Now this is again to look at the same thing in adults, and that's not entirely fair. This is HOMA. There's differences. You can ask whether HOMA is a good thing to do in a patient with diabetes, but in any event, again, what we're seeing is gradual loss of beta cell function with an x-axis that's measured in years, as opposed to here when we're looking at months. So again, what appears to be the case is that we have kids who are having beta cell loss more rapidly than in adults. Now, what happened in the lifestyle? And this is not fully analyzed yet. It's obviously there's reams of data. But what we found was that in fact, lifestyle worked in the sense that overweight, change in percent overweight was greater in the lifestyle arm in the first 6 months, but it was lost after 24 months. Or rather, the weight loss in metformin catches up. Okay? And it's only about a 4% decrease in weight. Now, that's about what you'd expect in adolescent weight loss trials. So the conclusion might be that it's not enough to change the course of diabetes. This just says the same thing. Now, was this an issue of adherence? And the answer is no. There's a variety of ways to look at that, but our adherence was 75 to 85% throughout the trial. This was an amazing adherence that is a testament to the relationship that these kids had with the study staff. And in fact, the adherence rate among the kids who fail was higher than the kids who don't fail, and that's because we started beating them when we knew their A1C was rising. And when you repeat the analysis based on the kids only with good adherence, the outcome is the same. So this is not being driven by adherence. Now, if we look at failure by race and gender, what we see is not much difference in the failure rate by gender, but a distinct difference with 39% of American Indians failing up to 52% of the African Americans. Now, if we look, however, at the arms, what we see is some very interesting and intriguing differences. So this is the time to event analysis, and this is blue metformin, green lifestyle, red rosiglitazone. And we see in the girls, rosiglitazone is statistically better than either of the other two arms. Whereas in the boys, rosiglitazone and metformin are the same, with a trend, a hint, a suggestion that lifestyle may be more effective in boys than girls. If we now look at ethnicity analysis, what we see, and was completely unexpected, was that in African Americans, metformin is particularly ineffective. So that by 1 year, 50% of the African American kids had failed metformin monotherapy, whereas for the Hispanics, the three arms were similar, and look at that blue line, response to metformin is much better. So there's an ethnic difference in response to therapy. So metformin monotherapy is inadequate for half of kids with type 2 diabetes. The role of intensive lifestyle interventions in youth with type 2 is at best uncertain. There are important race and ethnicity differences among youth with type 2 in the United States. And youth with type 2 diabetes have progressive loss of beta cell function that is rapid relative to adults and appears to be irrespective of treatment. So in light of today, what should the approach to therapy be? So keep in mind, metformin was effective in attaining glycemic control in 90% of patients who entered today's screening to get them to control irrespective of current medications. And this is published in Diabetes Care in one form a couple of years ago. We have another manuscript submitted talking about this. And basically what it shows for the clinical folks is that 90% of kids with type 2 diabetes can come off insulin initially, irrespective of their initial A1C.
The mean duration of 4 months.
What do you mean?
The mean duration of diabetes of 4 months plus your run.
Yeah, at diagnosis, right, absolutely. At diagnosis, and I'll show you some interesting more data. In addition, metformin was effective in maintaining durable control in the other half of the kids in today, although it was less effective in African Americans. Therefore, metformin remains an excellent choice for initial therapy in type 2 diabetes. Oh, this is supposed to be animated. Okay, that's all right. Now, we also, so now you've got 50% of kids who respond and 50% of kids who don't have a good durable response. What you'd really like to know is, who are they, right? That's the question we'd love to know. And without going into detail, what we know is that the baseline A1C is the primary predictor of the likelihood of failure, irrespective of therapy. And essentially, patients who do not normalize their A1C on metformin alone within a few months will be at higher risk of failure of therapy. Not decrease it to the ADA target of 7% or 6.5%, but non-diabetic A1C. Normalize their A1C. If they cannot normalize the A1C, their risk of failure is substantially increased. And over time, a rising A1C, even in the normal range, is associated with failure. So a rising A1C suggests the need to intensify treatment early, even when the patient has an A1C below what has always been considered our target. And these relationships are not affected by treatment group, by race, ethnicity, or sex. So what should we do? So what are the principles? Beta cell loss in adolescents with type 2 diabetes is progressive and rapid. Loss of beta cell function is the primary predictor of failure to maintain glycemic control in these kids. So, add-on therapy needs to address the loss of insulin secretion. Right? Next, Origin and other studies have demonstrated that treating to target, i.e. maintaining the blood sugar at your target, is more effective in the long run than stepwise treat to failure in maintaining target at 5 years. So what does that mean? Putting people on a drug and having the A1C rise and then adding another drug and having it rise and adding another drug is less effective than being aggressive, keeping them at target the entire time. They will require less treatment at 5 years than they do if you keep on adding things. So in other words, it's easier to keep people at target than to bring them back down again to target. So therefore, we want to select add-on therapy that will get the patient to target and keep him or her there. So what are our options? Sulfonylureas. I showed you the one study, and not much, associated with hypoglycemia. And I showed you from both UKPDS and ADOPT that probably sulfonylureas are associated with worsening beta cell loss or dysfunction over time. So probably not a good drug in a patient who is losing beta cells quickly. Incretin analogs, there are no pediatric studies. They're interesting. They associate with some weight loss, although in my clinical experience, not so much. There's some evidence that they may enhance beta cell survival, so maybe they're useful. They are injected, which is a downside. But interesting, but no studies. There's a study going on that has been enrolling for 5, 6, 7 years now. It's got 50 kids enrolled. DPP-4 inhibitors are endogenous enzymes that, DPP-4 is an endogenous enzyme that breaks down endogenous incretins. So inhibitors theoretically would increase incretins and help. There are no pediatric studies. TZDs, rosiglitazone, pioglitazone, no pediatric studies except the Today study, which is not a registration trial. We did see weight gain in our trial. However, as the clinicians will know, the use of rosiglitazone has been restricted due to cardiovascular concerns. Although this has now been reanalyzed and may not be true, it's probably too late. And the TZDs are probably dead, even if it was unfair in the first place. There's another group of drugs called glutamides, which are glucose-dependent sulfonylurea-like drugs. No pediatric studies. Acarbose, no pediatric studies. So, a little side rant here. Clinical trials for drugs of type 2 diabetes in adolescents. Currently, there are 15 intervention trials for pediatric type 2 diabetes registered with clinicaltrials.gov. Actually just got contacted yesterday about another one, so that makes 60. The total number of participants required for these studies currently is 3,500. There are less than 3,700 new cases of type 2 diabetes in the US annually, and only 40,000 kids in the country under the age of 18. So we're asking to enroll 10% of all the children with this disorder in trials. In addition, few of these kids are actually eligible for trials because many of them won't meet the A1C inclusion criteria for a variety of reasons that are interesting in their own. And I told you, this is a socially challenged group of kids, so most of them are not really good study candidates. So there's a very real possibility that none of these studies will recruit fully. There's a huge chance that every one of these trials will be futile, and therefore I have serious ethical concerns about this. Because to enroll a child in any trial, no matter how safe, that has no chance of actually finishing is unethical. So this is a real problem. Okay, so what do we do? So this is the ADA EASD treatment algorithm for type 2 diabetes from 2009. I liked this. Some of you know that in the next year they backed off and made it more of a menu and a buffet, and you can do this and that and this and that. I actually think this was very helpful. And what they basically said was there are well-validated therapies, and then there are those therapies that are not so well-validated. And the well-validated therapies are metformin and insulin. And then there's sort of everything else. And everything else is either less well-studied, more expensive, or less effective. And they say, well, look, at diagnosis, you treat patients with lifestyle metformin, and if they're not in good control, you add something. If A1C is greater than 7.5%, you add insulin, and if it's better than 7.5%, you add sulfonylurea. And if that doesn't work, then you intensify the insulin. And if you want to, you could add pioglitazone, you could add a GLP-1 agonist for a variety of special cases. But let me propose to you that what we need to do in pediatrics is what most of us are already doing, and that is something very simple. Lifestyle plus metformin at diagnosis, A1C greater than 6.5%, maybe even lower, you add basal insulin. Whoop. And if that's ineffective, intensify. So that we don't wait, we don't let these kids go to A1Cs of 7%, 8%. You have to intervene early, because these kids have a rapidly progressive disease, and we must do something to help protect them. So, practically, start metformin, A1C less than 9 or 10. I don't know what you guys do here, but I'm impressed that metformin can work even in kids with A1Cs of 10, maybe even a little bit more, although I had a girl who didn't work out so well. Many of these kids will actually decrease to the normal range within a couple of months on metformin alone. You treat as tolerated. If they have worse control, start metformin and insulin. Titrate the metformin, decrease your insulin rapidly. There's no evidence that going slowly helps any. If they have acidosis, then obviously you have to treat their acidosis. If they don't maintain control, add basal insulin, titrate as needed to maintain A1C of 6.5%. It's a change for me. I'm not putting up with A1Cs of 7 anymore, 7.5% of these kids, because I don't think it's in their long-term best interest for the reasons I showed you about the progressive nature of this disorder. And then addition of short-acting insulin. If you're not getting to target with a dose of insulin once a day of a unit per kilo. So, in summary, metformin monotherapy is inadequate for half of youth with type 2 diabetes. The role of intensive lifestyle intervention is uncertain. They have high rates, which I didn't show you, and increasing rates of hypertension, microalbuminuria, and dyslipidemia, as well as and/or cardiac damage. They have high rates of depression, come from families challenged by poverty, poor education, and widespread poor health. There are important rate ethnicity differences. Baseline and longitudinal measures of insulin secretion and beta cell function are the strongest predictors of failure of monotherapy, and prevention of deterioration in beta cell function will be an important approach to prevention of worsening glycemic control and development of complications in this population. And so I'll leave you with these questions that I believe are the most important main questions in type 2 diabetes. Why is beta cell deterioration so rapid? Can it be prevented? What are the approaches to initial and subsequent therapy in these kids? What are the long-term complication risks? What are the appropriate approaches to secondary prevention, management of the complications? What is the natural history of these durable responders? And what will the pregnancy and outcomes be in the girls who have children with type 2 diabetes? Thank you.
I know there's probably a group that have to go, so feel free if you have to get up and go. Otherwise, we'll take some questions from the audience. Yes, Dr. Clausen.
Great talk, very informative. I was just wondering, so you said the number of children makes trials problematic, but then I thought of the children's oncology group. I mean, if they'd let that stop them from, that, and I know it's a cultural shift and a new way of doing things. Is that possible in this area? Because then you'd have enough children and the new knowledge could be developed and all that.
I'm not sure you would have enough children, actually. I mean, you're still looking
Right.
to recruit 10% of the entire
But
population.
doesn't the children's oncology group, doesn't every new case almost get?
Yeah, so a couple of things, right? Life-threatening disorder,
Right.
not dealing with the social, right, problems that
Right.
we've got to deal with. This is an ambulatory study as opposed to kind of a, you're dying, here's your choices for therapy. So, we have those challenges. Now, you are correct, however, that the solution is not to have 16 independent
Right.
pharmaceutical companies, each with their own study. So in that sense, yes, if you could convince the FDA and the pharmaceutical companies to say, okay, we'll test one DPP-4 inhibitor and the FDA will approve all of them if it's effective. Then they might be willing to cooperate in this. But with the current sort of regulatory and competitive framework, it's not going to work. Because why would the companies cooperate if they're not going to get their drug?
You need FDA to come down with
The
this thing.
FDA needs to say, we will accept safety data and extrapolate from therapy in adults.
Thanks for that. That was really that's one comment. What is your comment about it being very difficult once you're above a certain level? I mean, that the beta cell is behind, and you speak to all those other things that started, and none of the drugs are starting them. So, one question I have is if any consideration has been given to the direct effects of these drugs in the beta cell, rosiglitazone in particular, because PPR gamma is expressed in beta cells. There is some evidence for that. My other question is, as you're following the decline of beta cell functioning, these kids, are there any more sophisticated measures being done? Like, I mean, for even pro-insulin ratios as a biomarker.
Yeah, we've got it. I mean, we have all this stuff. It hasn't sort of been out. So we do have pro-insulins in these kids. There's another study that's going on right now called RISE that's actually looking more carefully at early intervention effects on the beta cell. So the beta cell is the outcome in RISE. So we're taking kids and giving them different treatments, and for 3 months, and then looking 12 months later at whether we have done something beneficial to the beta cell in those kids. So that's our real beta cell outcome study.
Yeah, I just sometimes look at that and I think they just forget that we've got one way to do this.
Yeah, well, I don't think we forget. I think the problem is that the thiazolidinediones were given a ration to them.
Yeah.
And it's going to be hard to recover realistically, even if they're considered to be beneficial. It's going to be hard. And they gain weight, which, it's not horrible. I mean, actually, our kids only gained a couple of kilos, but it is tough when you're telling them to lose weight you know, here, lose weight, here's a pill that makes you gain weight. So we have to sort of figure that out. The weight gain wasn't very much.
Tom?
That's a great talk. Thank you very much for that. You know, one of the things that I was hoping to hear, and this is probably, you know, in analysis still, but what about the harder outcomes in terms of, say, you know, decline in renal function and things like that?
Yeah, I got it. I didn't have time. I
Yeah,
focused on therapy. I'd be happy to show it
Sure.
to you.
But part of the reason I ask, though, is that, you know, I've been impressed that, you know, at least some of the renal disease is probably independent of the treatment or control of diabetes.
Exactly.
There you go.
Yeah, there you go. So this is new cases of microalbuminuria, and actually many of them were macroalbuminuria, which is sort of frightening, and it was irrespective of treatment. It was entirely driven by glycemia.
So with that in mind, you know, all of the therapies that you're proposing, to my mind, they don't address why the person became insulin resistant in the first place, and the fact that they're still probably insulin resistant. It's just that you're able to give them enough insulin to keep their glycemic control good. You know, have we really started looking at the proximal event of why they've become diabetic in the first place, or insulin resistant in the first place, in terms of trying to address in a preventative way that type of approach?
Yeah, certainly. I mean, there's quite a lot of research going on. Our group actually studies these kids, trying to understand the nature of hepatic versus adipose versus muscle insulin resistance as it develops, you know, obese kids, pre-diabetic kids, girls with PCOS, to try to understand this. Now, it's, you know, how to translate that into prevention, it's really difficult to come up with this really needs to be a population approach to prevention. I think what John is doing is this, you know, figure out what the problem is and then try to develop interventions that change that. But it's the developing interventions that change that piece that's really difficult when you look at who these kids are. You know, they're poor, they're live in disrupted families. It's really difficult.
I think there's a big need to listen to the kids to see what they want, which we can talk about. Please, Jeff.
Two quick things. So, I guess I agree to move the adjustment. Your algorithm is Metformin add insulin. What are your feelings about starting with insulin?
I'm not as against it as I used to be, but I do have some hesitations, and my hesitations are more theoretical than anything. One of them is it does cause them to look gain weight, or it can, unless you're very careful.
It showed that the majority of ours don't.
Yeah, I know you have. But
maybe we're not using enough for control either, right? You know?
Well, your A1Cs are like 7 and 7.5, so maybe not. But you have to really work with these kids not to gain weight if you're on insulin. The second one I am troubled in type 2 and type 1 diabetes by the way we give insulin, which is peripherally. We are peripherally hyperinsulinizing patients. And the data is most interesting in type 1 because they're not making their own insulin. This is not good for you to be peripherally hyperinsulinized. Your pancreas delivers insulin to your liver, not to everything else first. And so I am troubled by the large amounts of insulin you have to give to get control, and what it may do to muscle function, adipose tissue function. And there's evidence that peripheral hyperinsulinization may be a risk factor for atherosclerosis. So given that 50% of the kids will do fine on metformin for a long time, and in fact, may have transient diabetes. We didn't discuss this, but a lot of these kids have become non-adherent, and they still have good A1Cs. Their diabetes is in remission. Given that, then 50% of the kids will get insulin who don't need it.
I guess it comes back to understanding it's a mixed bag.
It's a mixed bag, and in fact, I'm doing an analysis
Trying
right
to
now.
figure out, okay, who are those 50%
Exactly.
and be maybe more aggressive with insulin with the ones
Exactly.
who aren't.
And in fact, I'm deep in an analysis right now. We did an ROC curves to try to predict what A1C value you should start insulin, because the risk is so high. And it's.
And there clearly are kids who have horseshoes because they do diddly squat and they do okay. You know?
Absolutely. No, this is a heterogeneous disorder.
And John,
Absolutely.
one thing, the one that, and I know you weren't here to address that, Bill, I mean, I appreciate that, but your description of the population is like everybody else's description of the population, doesn't matter where you live.
Yeah.
And what I think we don't have any clue, if we don't really know what to do here, we don't have any clue of how to really operate, how to fix those problems to make adherence accepted.
Social determinants of
Yeah.
health. So you're talking about the social
Yeah.
factors?
And we
Absolutely.
can come up with the best treatment, we still gotta make it work in the.
Absolutely. And if I was gonna go back and redesign today, sorry, John, I'd get rid of the lifestyle arm and I would have put a social work arm. Caseworker. This is what these kids needed.
Psychology.
Yeah, exactly.
Second last question, so I'm going to take the last question.
At some time, I was just wondering what would be your comment on establishing having the DPP4 inhibitor or the incretin analogs for the pediatric type 2 diabetes, considering that their beta cells are rapidly on the way that they're losing it, and they are already exhausted and overwhelmed in response to the insulin resistance of their pubertal stages, would be a good option.
They are interesting. They're intriguing, right? I mean, particularly the incretin analogs are interesting because they maybe would be helpful. We just have no data. We have no data whatsoever about these kids. Again, there's a trial of exenatide. It's been going on. It's sitting like a dead fish, out in the sun. They've got 50 kids enrolled after 5 years. It's not going anywhere, so we just don't have any idea if it's effective. You could say, well, it should be because the beta cells, are dying, but maybe because they're dying so fast, it's not going to be effective. I don't know. I just don't know. And there's DPP4 inhibitor studies, but they each have like 10 kids in them at this point. There's nothing. There's no data.
If these beta cells are failing at 14, is this really type 2 diabetes? Or is this a genetic? Or are we missing the boat somewhere? Is there something?
Yeah, well, the answer is yes, to both, right? I mean, it's type 2 diabetes by our definition of type 2 diabetes, which is that it's non-immune, it's non-immune, resistance with inadequate compensation, so whether the definition of type 2 diabetes needs to be changed globally, maybe. Now, what is this? Why are these kids failing so fast? I think you're right. I think it's genetic in a sense, but I think partly maybe ascertainment. In other words, who gets diabetes at 14? It's the kid who is at risk for rapid beta cell loss, probably because of some genetic background. And typically what you see is, grandma had diabetes at 60, mom at 40, it's just sort of progressively going down. It probably is genetic risk for early beta cell loss that's being selected in a toxic environment. So I don't think it's because they're pubertal they lose beta cell. I think we're picking them up early because they're rapid beta cell losers.
And the affluent kids who may have the same genotype,
They're not in that environment.
they're not.
And they're going to get
They're
it.
not getting this.
They're going to get it when they're 70. Like a lot of, my grandmother
Or they're-
got diabetes eventually, but she got pretty old before it happened.
All right. Well, thank you very much.